All right, welcome to our discussion of evidence-based practice, what it is, what it isn't, and why do we do it. Let's talk first about what evidence-based practice is not. It's not a new fad that just sort of jumped up out of nowhere. We've been using this for a long, long time, and so have other clinicians and professionals from a variety of disciplines. Certainly, the past 15 to 20 years have seen a stark increase in the discussion of the need to support what we do and why we do it. But it's also important that we have this kind of evidence because third-party billing and professional organizations want to know that what we're doing is effective and it has a research base. But evidence-based practice isn't only a research issue. Um, there's multiple forms of evidence that might be used because we need to look at the use of the best available evidence. We'll talk more about this later. And finally, evidence-based practice isn't something to be afraid of. It's a good thing to carefully consider what it is we do and why we do it, and there's many tools to assist in searching for evidence for what we do. So what is evidence-based practice? Well, Sackett and many colleagues are often the most cited authors related to evidence-based practice, and their discipline was medicine, but we've sort of incorporated their definitions into our own practice or our own concept of evidence-based practice. And a standard definition of evidence-based practice comes from Sackett and their colleagues, who defined evidence-based practice as the conscientious, explicit, and judicious use of current best evidence in making decisions about the care of individual patients by integrating individual clinical expertise with the best available external clinical evidence from systematic research. From this early definition, you can see that both research and clinical expertise is a part of evidence. We'll talk more about clinical expertise a little bit later. But in 2000, the same authors updated their definition, and this time around, they included patient values so that the definition now includes statements like evidence-based practice is the integration of best available research evidence, expertise, and patient values. It's a combination of internal evidence to a specific treatment, that is clinician expertise and client values, as well as external evidence, which is really the best available research evidence. So there's a lot of factors that go into evidence-based practice, not just research. So here we have a representation of the three sort of facets of evidence-based practice, often described as the evidence-based practice triangle. You can see here that evidence-based practice is not just based on research evidence. Clinical expertise and client values count for quite a lot. And a story that I often tell is of an elderly man I was treating in the nursing home. His diet was for regular solids and thin liquids, and I was working with him on cognition only. But I saw him over lunch one day trying to fit him into my busy schedule, and as he was eating, he coughed and coughed on his steak. It was hard to chew, and he was kind of choking on it. And I could also hear when he drank the most awful gurgling sound in his lungs. It was really horrible. So clearly his diet needed to be evaluated and probably altered. Both the research evidence and my clinical expertise was telling me that this was the right thing to do. But when I contacted his family, who had healthcare power of attorney, they were adamant that his diet not be changed because he had always really enjoyed eating and drinking so much, and he didn't have time to live. He didn't have very long to live. And they said it was a quality of life issue for him. And nothing I said about the dangers of pneumonia or really choking would change their mind. It was a very strong value that they had for him. Um, So clearly, the client's family's values trumped the other 2 points in the triangle in this case. So client and patient values do count for quite a lot. So what is evidence from research when we talk about those current best evidence, current best practices? Well, these are approaches that are well researched with a specific population in mind. We may use them with other populations sometimes, but we're also driven by this question of what is good or useful research. Right? Um, it's theory driven. This evidence that we get from research has an underlying theory. Okay, some approaches are well researched, but they're maybe not driven by theory. And so you kind of have to make a judgment call about what is the best evidence in that case. When that happens, when you get an approach that is um, not terribly well um, underpinned theoretically, but that are well researched, then you have to make a careful, thoughtful consideration of the best evidence. And here we have the Oxford classification, which is a way of designating evidence into categories according to which evidence should carry the most weight with us when we implement evidence-based practice. You can see that the highest level of evidence comes from those studies that are most highly controlled, such as randomized control studies, often conducted as clinical trials. The best evidence also comes from a systematic review of more than one highly controlled study. Remember that one study by itself doesn't really constitute a fact or definitive conclusions. We need more evidence than just one study. You can see as we progress down the list, the types of studies become less highly controlled. So case studies with a control person is better than a case study in which there was no control subject, for example. Keep in mind that level 5, expert opinion, provides the least evidence and should be taken with a grain of salt. But overall, we don't want to get too caught up in designing a perfect level 1 study because in reality, some research questions don't lend themselves to highly controlled, randomized clinical trials. A question such as, how do the spouses of people with dementia cope with their partner's disorder, is still a very good research question, but it can't and shouldn't be answered in the same way that we would ask if something like the spaced retrieval technique for memory loss is an effective strategy for recall with patients who have dementia. So don't discount lower levels of evidence outright. Be aware of the research question and the methods that could best provide an answer to it. One thing that always trips students up, and it tripped me up when I was a student, is the concept of efficacy versus effectiveness in research studies. Treatment efficacy involves highly controlled research under the best possible conditions, such as a laboratory. The clinician is highly trained and usually has some expertise in the treatment that they're giving. The subjects are specifically selected based on their characteristics. When we see a treatment that has good efficacy, we know that under ideal conditions for the typical client, the treatment should work. When we want to know more about how treatments should work in the real world, we may conduct a treatment effectiveness study. This type of study lacks the high levels of control that is necessary for treatment efficacy studies, but may be more realistic for clinicians who are out in the field and may have clients who are not typical or do not work in ideal settings, meaning that the treatments may not be offered in these pristine laboratory type conditions. Let's talk now a little bit more about clinician expertise. If you want to be an ethical clinician who uses evidence-based practice, The most helpful things that you can do is to have a healthy uncertainty about whether a clinical action is optimal for a client. We don't want to be so optimistic about a treatment that it blinds us to whether it's actually working or not for our client. And we always want to demonstrate professional integrity. That means having honesty, respectfulness, awareness of our biases and those of others, and openness to the need to change one's mind. Clinician expertise is also an interesting thing because sometimes it may sort of blind us to the need to do more research. We may say, I do what works because I know it works. This isn't the best evidence, definitely, because if the clinician is clearly doing something that has little theoretical or research support, it's very difficult to say whether that particular treatment is efficacious. But clinical expertise shouldn't always be disregarded. Experience matters, especially when certain approaches have a good theoretical basis, but can't necessarily be researched through traditional methods. Some stuttering techniques that relate to attitudes and emotions are like this. If this is the case, we always want to incorporate a more eclectic approach to therapy using different levels of evidence. Let's return to discussing client values. They're so important, and yet we don't have a ton of information about how we have traditionally factored client values into clinical decision making. We know that we must calibrate best available evidence and clinical expertise to our clients' values and needs. Researchers in fluency have studied this, probably because there's a debate about what the best approach to stuttering treatment is. Do you teach people to be as fluent as possible, or do you teach them not to hide their stuttering and to manage their stuttering as it happens, freeing them up from emotional worry? SLPs who work with fluency clients will have to take their clients' values and preferences into account when they design their treatment plans. Let's talk now about ethics and our role in evidence-based practice. There are four ethical principles that we should apply whenever we make clinical decisions about and with our clients. These are beneficence, non-maleficence, autonomy, and justice. Beneficence describes approaches we should choose to have maximum benefit for our clients and their families. That should always be our goal. Non-maleficence is just a fancy way of saying minimize harm to clients. We might even say do no harm to clients, just like the doctors say. Um, Autonomy is where we think of clients as individuals, not numbers or disorders. We need to value their need for self-determination, and we must respect their rights to make choices about what happens to them. And finally, in terms of justice, we should strive for fairness in all we do and be advocates for our clients and their families. We never want to discriminate. As we wrap things up, we want to make sure that we are thinking about evidence in the right way. We need evidence because as humans, we tend to look for evidence that supports what we already believe. We should do the opposite and instead search for answers in an open-minded way. We also want to avoid subjective bias. That is, expert opinions and testimonials that may prejudice us to thinking in a certain way, but may not have evidence to support these opinions. We also need to be able to find resources that help us explore the right answers. One way to find answers is to have a good question in mind. This is where the PICO approach comes in handy. In this four-part approach to writing questions, we must clearly identify P, which stands for the patient or problem, I, meaning intervention, including treatments and diagnostic tools. C, comparison or contrast to the intervention. And O, outcome of the intervention. For example, we might write a question such as, does use of the LIDCOM program for preschoolers who stutter reduce stuttering as compared to preschoolers who do not receive any fluency therapy? Another question might be, do elderly patients with aphasia who undergo constraint-induced intensive therapy as compared to no therapy perceive an increase in their communication abilities? The PICO format is the cornerstone of good question writing and is something that you will be able to practice in this unit.